Welcome, everyone. Thank you so much for joining us today. This is another one of Wellspring's Be Well Talks. And so today's topic is on the psychosocial impacts of genetic cancer. And so I'm happy to share that this webinar is presented in collaboration with Pancreatic Cancer Canada in honor of Pancreatic Cancer Awareness Month in November. And so while this webinar is in collaboration, I do encourage anyone with any cancer diagnosis who is interested in learning about the psychosocial impacts to tune in and see what they can take away from today's valuable webinar. And so I'm excited to also introduce Maureen Elliott, who is a senior program manager of programs and support at Pancreatic Cancer Canada, to introduce our speaker for today.
Thanks, Benita. I would like to warmly welcome Dr. Mary Jane Esplen, pardon me, professor of psychiatry who's held several leadership positions, including two distinct vice chair positions at the Department of Psychiatry, Psychiatry Faculty of Medicine in the University of Toronto. She is a recent vice chair of the Equity and Mentorship Department of Psychiatry and chair of the Canal Committee for Faculty of Medicine, a former clinician, scientist at the University Health Network and Mount Sinai Hospital, founded in D'Souza Institute, a national center for education for oncology health professionals. And she has held career scientist awards from CIHR and NCIC for her psychosocial oncology research, completing studies of psychotherapeutic assessment tools or treatments to support adjustments to being diagnosed with cancer or receiving genetic risk information in breast, colorectal, or pancreatic cancer. And we are really looking forward to her presentation today. So thank you so much for joining us. Thank you, Mary Jane.
Thank you. Can everybody hear? Can you hear me?
Yeah,
Okay.
audio is good.
It looked like somebody had their hand up, but I don't know what that means. Is there anything to worry about or a question?
I'll take a look. I'll take a look at the chat, but I can hear you, and I think Maureen can
Okay.
as well. Thank you.
Thank you for having me. And for those of you who are coming, I'm going to give kind of an overview. I worked a lot in breast and colorectal, a little bit in pancreatic, and I know that people may be joining from across Canada in various areas of cancer, but I think you know this if you've probably come to the webinar, but just to remind you that the familial or the hereditary cancers are a smaller proportion of all of our cancers. That, often oncologists or surgeons refer to cancers as sporadic. It's a term they use, but they're the cancers that are more common that we don't even know what always causes them. But it's an interesting group, the ones who carry a high risk or these risks that run in families. It's autosomal dominant. The cancer genes now have been cloned. I think they first started cloning the genes in 1994, 1995 or so, the mid 90s. And so now genetic testing's been around for a little while where they identify someone, they start looking and taking a family history and can able to, they call it an index case. Usually somebody diagnosed with cancer starts the genetic testing process in a family. I just want to focus on the psychosocial aspects today. And I believe that if you were at a prior seminar, you heard a little bit more about genetic counseling per se. I work more in the psychosocial area. There are some unique aspects of genetic information, um, in addition to receiving cancer diagnostic information. It's a little bit interesting and a little bit different. First of all, even though you may receive information around a genetic mutation or a high risk in a family, it's still probabilistic. We don't always know for sure if somebody will develop cancer. The genetic counselor may give you a risk estimate, but it's pretty complex and there can be other factors involved, and we don't know when a cancer might develop, if it's going to develop. And then, control may be variable depending on the type of cancer. And Huntington's is not cancer, but Huntington's is 100% penetrant. You have a 100% chance of developing it. And we don't have as many cures around Huntington's. But, one of the things we do have in the cancer area are some prophylactic or treatments that you may be able to do. But in addition to getting genetic information, we know that you may not have all control over whether or not you develop the disease. We also are talking about a risk level, about an event, if you haven't had cancer at this point, that may occur in the distant future. So it's different than a very concrete diagnosis when you get told you have an actual cancer. And I consider it life-altering information. It's an impact, it's life-altering, potentially pretty life-changing. People talk about, before genetic testing and after genetic testing because the information you receive reminds you about the finiteness of life, and it has implications for your life as well as those of your family members. So it is emotionally what I would refer to as emotionally laden kind of information. And then there are other challenges that some of these have been worked out, but in the early days, people weren't even sure where to store genetic information. There can be confidentiality issues. Do you want it in the file? Implications for insurance and that kind of thing. And it's very sensitive, and there are specificity issues. Now that this has gotten way better than when I started doing research in this area. Used to be that, they give you information and the tests are pretty good and they've gotten better over the decades. But sometimes there were specificity issues, meaning was it really accurate? How much could you really rely on the test? But that's changed quite a bit. That's improved. The sensitivity, the ability of the test to do what it's supposed to do has changed. So now I want to just point out, and a lot of you would know this if you have a family history of cancer, people that come to the genetic testing consultation or the whole area, they often have a very high level perceived risk. They often come to the encounter with the genetic counselor or the geneticist, assuming or thinking they're at high risk. Sometimes they even overestimate because they may get a number or a category of a number. And they often think it's somewhere up around it's 100%. I'm pretty sure I'm going to be the one to get it. And this is often because of a family history, or if you had a parent with cancer, it can lead to a very elevated risk perception of having the same cancer. We know, and even before the genes were cloned, people were documenting in the research literature the psychological impact of having a strong family history, fear, sense of guilt or worry about offspring, grief. A lot of individuals coming to the genetic testing encounter have had a lot of losses in their family due to illness. And then we knew that it was impacting screening adherence in different ways. So sometimes if people have a very high level of worry or concern, believe it or not, they may avoid or not even want to go for some of these surveillance measures or the screening tests to be followed and monitored because they get so anxious around screening exams. And others want to be screened frequently. They're so worried about it. So we were already documenting that even before the genes were cloned and genetic testing was available. These are some quotes from patients. I've worked a lot with patients in the area, and I hear this all the time. My mother got cancer, then my sister, and I started to worry. Um, this is interesting, and there's no, it shows you how beliefs can play a role. There's no evidence to suggest if you look like somebody that had cancer in the family, that you're going to carry the same gene mutation. And if there is a gene mutation for cancer discovered in the family, your offspring has a 50%, there's a chance they can carry the same gene mutation. But again, it's not based on whether they look like the person. But people develop beliefs. I think it's going to be me. I have a certain personality like my dad or my mother, or I look like my father, so I know it will be me. So people do form beliefs based on the prior family history. Of course, there is a sense of, can I control this? Is there anything I can do? I'm here. These are one of the motivations for genetic testing. I'm here because I want to learn about anything that will give me a sense of control. Others may avoid and not even be sure. And this can happen in the same family where two siblings one may want genetic testing and a known, and somebody else may not want to. I don't know I'm better not knowing. I don't want to know about something I feel I can't control. So there can be different reactions to the whole idea of genetic testing. The other thing that we know is that it's a family affair. It's not really the genetic information itself has relevance for other people. And so often parents or people will say, I don't know if I want to go through genetic testing. This is going to open up a whole can of worms in others in the family. And I've seen a lot of this. I've worked a lot with parents. I've met a lot of people that had a parent with cancer, and they say things like this. This is the worst part, thinking that I could pass it on. They know it's not their fault if they carry a gene mutation, that a child may carry the same gene mutation. They know it intellectually, but that doesn't mean they don't always feel some guilt around it. It's a more difficult emotion to talk about. And somebody else said, I need to do all I can to help my daughter and my granddaughter. Actually, learning about offspring is one of the key motivations for genetic testing. This is another example around Gwilt. My mother knew she had this gene. She would have been devastated that she could have passed it on. I want to spare my daughter. That's why I'm here for testing, to find out what I can do. This is another well-documented area of emotions around genetic testing. And again, I certainly have seen families with multiple losses over generations. Not all families, but some do. And you can really see it, when they draw out your background, like when they draw, when you go for genetic testing, they document all the cancers in the family over as many generations as they can. And they draw it out and you see it. They put a stroke through if there's been a death, like you can see it, right? I always said to the genetic counselors, it kind of opens it up visually, like it opens up the emotions just doing that procedure where they're documenting all the cancers. And these are quotes from patients. I've lost a sense of innocence. Every female has died in my family prior to 50, and that's quite extreme, but it's possible that it's happened in some families. I feel like I've lost something again. This person's referring to the actual genetic test result. I feel like it's a lost again. And I lost my mother. She was taken away too soon. And this is what I was talking about when they draw out your family history and, the stroke means the death. They put the age, they're documenting the types of cancers. It's a very visual exercise to go through and can be very emotional. So in a way, I've often thought about this as the genetic information and genetic testing. It's looking back in your background, looking back in your family background, but also about looking ahead and looking at future generations. That's really the nature of this information. Now, what do we know from the research literature? Well, these are the most frequently cited reasons for people wanting to go through testing. It's been well documented in the literature. They want to reduce uncertainty. They may have a sense they have a family history. They may have a sense they have a gene mutation. They want to find out if, in fact, they do or not. To participate in research in the early days, this was a strong motivation to explore, should I be doing more? Do I need to be in high surveillance monitoring programs so that I can be watched? Is there anything I should be doing treatment-wise or prevention-wise? Even lifestyle-wise, people want to know. And then sometimes people are making decisions around childbearing or other decisions. They want to know that might help inform some decisions they're making. And this is a big one. This is a key motivation. People do want to know, regardless of the age of their offspring, they're really curious about offspring and the implications for offspring. Now, these are the factors that influence that interest in genetic testing. So, in general, people that feel they have a high level of risk for a certain cancer are more interested than someone who may think they're at lower risk. Feeling worry or threat of this whole area, feeling vulnerable because of that family history can be a strong motivator. Personal relevance, what I mean for that is if somebody feels they look like somebody or they're getting close to the age that maybe a parent had cancer, then all of a sudden it's even more relevant. I put depression too because there have been a couple studies that show that individuals with some depressive symptoms have chosen not to go forward with testing, which is interesting because it may be kind of like a protective factor for themselves that, they've declined the offer of testing. There's been a couple studies to show that. Education, often higher. This has changed though as genetic testing became more available, but it was often individuals with higher levels of education were pursuing testing. Women were more often than men pursuing testing. That may have changed. And then treatment options. Again, people in general are more apt to go for testing if there's something they can do, or they know that there could be something they could do, or they want to find out if there's something they could do. And then culture. And again, this has changed over the years, but in the early days, most of the research studies and most of the people coming for testing were Caucasian background. That's changed because there's been a lot more outreach and accessibility of offering genetic testing to diverse populations and making sure that populations have access. So sometimes that's involved outreach programs. And then socioeconomic status has played a role in some of the research. So people of higher socioeconomic means were pursuing testing more often. So what do we know from the research? What do we know clinically? What do we know from people? Say you go through testing and you get told indeed you do have a gene mutation for one of the cancers, or you're at high risk now. So they start often with the person who has a diagnosis already of cancer because they call them sort of the index case. They know they've had cancer, so they start with them before they may offer people that have been that are in a family but not yet ever had a personal diagnosis. We sort of refer to them as unaffected at this point. It's just a term that's used. So this is what we know with people that have already had a diagnosis of cancer. It actually helps them understand why they developed cancer. And I've met many, many people over the years. I've worked in lots of areas of cancer, not always genetic testing areas, where people tend to blame themselves or wonder if they did something that caused the cancer. So it does answer that question. It's not something they did. They carry a gene mutation. They can be often the ones who feel right away, oh my goodness, I may be passing this on to a family member and an offspring. It's a very common reaction, even if they don't disclose it right away. There were in the early days, this has been dealt with more in the ethics literature and insurance, but they do wonder about insurance issues. And then right away, the person that's been tested first or the one with cancer often has that first job of having now to start letting people know you might be eligible for testing and you probably should be going for testing and encouraging people in the family to follow. And for some, depending on the nature of the cancer, there may be surgical decisions to make. I mean, I worked a lot in breast and ovarian cancer, so people that carry the gene mutation for breast cancer may not have been aware they could be at elevations for ovarian cancer. And if they finish their childbearing, for example, they may be offered prophylactic removal of the ovaries. Or with colorectal cancer, you may be offered hysterectomy or to make sure that you're lowering the risk for endometrial cancer. So, and if you're not in screening programs, you will be put into follow-up programs to make, even if you've had breast cancer, to make sure that monitoring the other breast, or you may even be offered a prophylactic mastectomy. Now, what do we know about people who have never had cancer, but they're going through testing and they test positive, indicating that they have a gene mutation? So right away, these are some of the common reactions. Now they have, sorry about the second C, they have increased certainty about their risk. They now know they're at greater risk. They can feel, this is a term in the literature, like, when we're younger, it's pretty common that people feel invulnerable to illness, or, we're not always thinking, younger populations of the general population aren't thinking about chronic illness so much or serious illness at a younger age in their 20s and 30s or 40s. But for people that are from these families that may have cancer running in the family, they feel often an impaired invulnerability. They don't feel so invulnerable anymore. They actually feel more vulnerable. They can experience grief. You heard the patient that said, it feels like a second hit. I've had a lot of loss in my family. This gene mutation is like a loss. Isolation, a sense that others their age may not understand, their friends may not understand. Notification to family is an issue for many of them as well. Maybe I want siblings to go or cousins, or you may have the job to reach out to have family members. All of a sudden now they're going to be in follow-up programs. They're going to be in high-risk surveillance monitoring programs, and they want to be watched usually, but that can come with some anxiety and fear that comes with those screening tests and being followed. Like, it's very common to get a little nervous or anxious before you're going for whatever the surveillance test is. And until you get the test result, that anxiety does not always come down to a more general level that you're more accustomed to. And, there's different tests, and some of you may be in MRI screening and follow-ups. They may have, just like the ones with cancer, they may be offered prophylactic treatments or options to help reduce their risk to cancer. These are now being offered more routinely. And there are other impacts. So a lot of these, just having somebody monitoring you and you're very hyper aware of your body and your body functioning and you're looking at your functioning, or you've had prophylactic surgeries, that's going to change your body image and your sense of your body and your sense of self. It may lower your fear risk and it may make you feel you're at reduced risk, but it comes with some residual impacts. These are some of them: sexual functioning and quality of life. So if you've had a removal of ovaries or a hysterectomy, you're going to go into menopause if you haven't been in menopause, and you're going to have other kinds of residual impacts. And there can be other prophylactic surgeries like removal of stomach or removal of parts of the colon for FAP and other areas. You're going to have changes in bowel functioning or prophylactic mastectomy. They may give you reconstruction, but they're not going to feel the same as your original breasts. So you have to adjust, and these body changes can have impacts that have psychosocial impacts. And then, as you probably know, if you're a family member or caregiver, there are lots of follow-ups for the rest of your life. And there is something called scan anxiety. I mean, this is the anxiety that is very related, and it's very understandable and very common around the screening tests and the follow-up. Now, these are some quotes again from patients I've worked with about they want to have often prophylactic surgery. It can be a tough decision to make, and you'll be confronted with, what are the pros? What are the cons? Is this for me? And two siblings in the family can have different reactions around the offer of prophylactic surgeries. These are quotes. So for one patient, she said it's kind of self-inflict surgery. It's a very hard decision to make when I don't even have the disease and I feel healthy. Somebody else said, I'll be having surgery in a couple of months. It's an easy choice because I don't want to live with fear. They're doing it. They're very motivated to reduce anxiety. Somebody else said, I want to do all that I can. And somebody said, I felt prepared for the surgery and physically I've been pretty good. But at an emotional level, I feel different. This is a woman that had her ovaries removed. I feel older. It's affected my sense of femininity and who I am. She went into menopause and she wasn't sorry she had the surgery, but she wished she'd felt more prepared and knew more information going into that surgery. And we've done better than, often that is an important area we need to think about in the care. Yeah, that's the same quote. Yeah. So disclosure, this is also a very challenging area because, it's not that straightforward. When do I tell an offspring? Or say you're having to be the one to offer this or suggest to other family members or cousins you don't even know well that you're going to open up this can of worms, or you don't even know them well and you're introducing the notion of a sensitive topic. This is from a mother. I didn't want to tell my daughter at that moment my test result. Her whole life's ahead of her. She's only 24, but I wish I hadn't lied. This is a woman who was driving, and I think the mother asked her, she let her daughter know that she was going for genetic testing, and the daughter asked her in the car, well, what was the test result? She wasn't prepared at the moment. She got ambushed a little and just said, it was all fine. And she said, now I have to find a time and a way to tell her the truth. And that can understandably happen. And then impacts on relationships. So others, if you're a younger person, or even if you're midlife or even whatever stage of life, if you haven't had a family history of cancers like some of these families have, your peers and friends may not understand why you're going for all these follow-ups or why you're even thinking of something like the removal of a healthy organ or removal of a healthy body part, like in prophylactic surgeries. You may not be comfortable discussing the area of genetics and cancer risk with your friends and peers. And you're not wishing maybe to offend people or distress. You may feel protective, like I don't want to open this up and talk about my own issues or even worry about their, risk and make them feel sensitive or worry. So some of this is due to their own fear of the disease and fear of death or loss. And this is a cartoon, but it's not, it's a real reality. I ran into this a lot. I did a lot of support groups for people that carry genetic mutations. It was part of my research. And then I ran a lot of clinical groups over the years. And she's got the human genome report in her purse. And, she's saying, let's be friends. And he's thinking it's his DNA. This question of dating, if you're a young person, never had cancer, and then you have to let someone know that maybe you're in a dating relationship. When do I have to let them know? Do I have to let them know? It gets very complicated. kind of a tough topic. Somebody said, I want a husband. This is somebody saying, well, I'm going to pick a partner. I want a husband to be there for me. But when do I tell the boyfriend I'm a carrier of a gene mutation? And do I actually have to tell? But she also was looking for somebody. She used to say, actually, I want somebody that if I have to have chemotherapy, is going to be going to appointments or hold my head over a toilet if I need to have chemotherapy. Like she's very clear that she wants a certain kind of mate. Now, we do in our field measure actual symptoms of psychosocial distress, and there are measures of depressive symptoms and fear and anxiety symptoms. And you can see that when you look at after somebody with a mutation, after they get their results, there is some elevation in anxiety and can be in depression symptoms. And it's approximately 10 to 25% of all the different people that may have what we would call even a level that warrants either medication or some sort of treatment. Subclinically, though, that gets more into when you're measuring fear or cancer-specific distress. Like they're maybe not anxious in general or depression in general, but if you ask them questions more about anxieties or distress around cancer, then you get a higher rate. So that can be up to 50% when you measure it. And we talk about something called the stress response syndrome, which is a kind of a stress response to a very specific stressor. So in this case, it's the elevated risk for cancer. And again, there are criteria to actually meet a syndrome, which might require some psychological treatment. Only, under 20% might meet the full criteria, but it's not uncommon that people want to avoid clinics or avoid symptoms or feel very, you may relate to this, very watchful, watching your partner or watching yourself, monitoring your body, even if you get the flu, wondering if something's happened. These are some, you can be very hyper vigilant, very hyper alert. But the good news is, even when you measure these clinically relevant symptoms in my field, even though there's elevation over time for the majority of people, the good news was that we found that those elevations in distress comes down over time. It may depend on what's happening, if surgeries are happening or another diagnosis in the family. This is very dependent on the context. But in general, we find that people adjust over time. There is a subset, and I was always interested in working with them. There is a smaller group who remain more distressed over time, and they need more psychosocial support in the genetic testing and counseling process. And then there's a larger group who continue to have worry. It's manageable, but they probably would benefit by some support. And we've also documented on the partner and the spouse or the caregiver, they can also worry, obviously. They also are part of the picture. And well, when do we tell our offspring? At what age? Should we tell them? How do we're worried about them, but we don't want to cause any harm. We want them to be young and a teenager. When do we start to tell them? In most of the cancers, genetic testing is not offered until you're at least 18. They're usually adult onset syndromes. But we have a few syndromes that run in youth, and one is familial endematous polyposis, FAP. The genetic testing is offered earlier, depending on the age of early onset in the family history. So there are some where we offer testing younger. But again, there can be positive effects. A lot of people report being closer in their marriage, that it brought the couple closer together. Other family members, in these families, there's often a lot of stress, a lot of diagnosis happening. The context plays a role. There can be feelings of, I've seen this, well, let's tell Aunt so and so, but maybe we won't tell some other family member because they're too vulnerable or they will worry. So sometimes people figure out who they should tell or feel the duty to tell somebody more than somebody else. And that's something the genetic counselors try to deal with. The big question for a lot of people, okay, I'm going to tell the offspring, but when and how do I go about that? And then there can be ethical challenges around not telling, then people don't get information that might be relevant to their health, or feeling blamed for telling, or feeling a lot of pressure to enforce that people go for testing when really people do have a right to not opt for testing. So there are some ethical challenges. The teams and children have told us in general, they have a desire to be involved in the process. They do feel they'd like to know. We've interviewed them, and there have been studies and looking at the literature. They seem to be doing okay with the information. And so the early studies are pretty encouraging. And that might be dependent on the child and personality and other factors, but it's been encouraging. And then there are other relevant factors like the family dynamics play a role when people are estranged, or there's challenges in family communication or anxious kind of families. How close they are can affect how this gets communicated over generations or among family and distant members and close members. Culture can play a role. Like sometimes there are cultural beliefs around genetics or illness, or whether you should tamper with anything. I mean, there can be cultural factors. People can feel very isolated. And then the other things to think about, what else is going on in the family? There have been situations where sometimes somebody's been very ill and at a palliative stage in their cancer illness. And yet people want a blood test because they want to know, was the cancer, inheritable? And it's very awkward, somebody's in the dying phase or at end of life, trying to have those conversations and give informed consent. So there can be other things that go on that play a role in a lot of this area. Now, one of the things I did in research, and I did it in breast, I did it in FAP, and I did it in colorectal cancer, I was really interested on how this impacts on the person, not just measuring anxiety and depression or mood or measuring even perceptions. I wanted to know about how do people view themselves that carry a genetic mutation after they go through the genetic testing results. So we developed a number of we call them instruments or psychosocial tools to help get at that. And this was all based on interviews with families and the research literature. But they told us, like we first went to the families and the members, how do you feel carrying this genetic knowledge? And the reason I was interested in this is that, we all have a sense, this is not about just genetic families or inheritable cancers. We all carry a sense of who we are in the future, who we are now. They're called schemas. They're kind of active working images and structures, beliefs about ourselves. They shape our perceptions, how we remember things, and how we think about our health and all our behavioral and challenges in life. So we have a present sense of who we are as a young person or as an old person, how you might describe yourself. Like it would be the descriptors you use. How would you describe yourself? Like you might say, I'm athletic, or I'm kind of a young person for my age, or I'm a smart person, or I'm an attractive person. Like, we have images of how we view ourselves in the past, and we also carry a sense of how we see ourselves in the future. For example, how we age or how we may see ourselves over time around illness or around anything, aging, illness, careers. So there are these possible selves kind of schemas. And then we might also base it on what people expect of us, our culture, our fears, what we hope or ought to happen in our future. And they're very personal, they're very detailed, they're usually very enduring. They've come based on our past histories. And it may have to do also with what you're striving to become or hoping to avoid becoming. So this is just like psychological theory around what a view of ourself, how they're constructed and what they mean. So we did a number of these scales, which were developed for the field of genetic testing. And these were some of the impacts we saw. Some people, and people vary to what extent, and these, when it says subscales, these were characteristics and themes that in our statistical analysis held true and really were robust findings. People vary on them, but they were part of the story. So, stigmatization. For some people, a genetic test result makes them feel different than others. I feel different than a healthy person or different than a person without a mutation. I've heard these comments, I feel like damaged goods. I have heard those comments, and people vary on this. I feel not isolated. I feel, yeah, there are different words that people have used. Vulnerability, like I mentioned earlier. Interestingly, there are some positive sense of self items we saw. So people feel empowered. I feel a sense of control over the genetic information. I feel resilient. I feel, I have something that will help me in my future and empower me, say, compared to somebody in a past generation where they didn't have genetic knowledge, they may be at high risk for disease. And then there were a number of scales around body image. And we found this, for example, in the colorectal cancer areas. I'm monitoring bowel functioning. I'm very aware of my bowel functioning, but there can be other body image. I feel less attractive, people might feel, or I feel I have to be careful about body functioning. I'm very aware, I'm monitoring, I'm very vulnerable around certain symptoms. And all these skills have been demonstrating and being worked at in different cultures, actually. And a lot of these sub-skills have held true. So I just wanted to give you a little bit of a deeper dive around some of these impacts as we were looking for ways to understand it so we know how to actually help people and support people. Now, what about if you test negative? I want to touch on that because some people get told good news. Even, somebody else might test positive in the family, but they get good news. You don't carry the gene mutation that was discovered in the family. Most, as you would expect, feel better. They feel relief. Their stress goes down. They worry less. Interestingly, a smaller subgroup have difficulty adjusting, and that's because, some of them had really strong family history. And it's part of their sense of self. They feel at high risk for cancer. I wouldn't say they necessarily don't believe the result, but they don't feel 100% sure it's gone, the risk. It's really hard for them to think they're at the general population risk or something. It's hard for them to sort of change that perception of being a high risk family or carrying mutation for cancer. Some feel guilty that they got a good result while others didn't. That's a very common reaction. And some can feel isolated. Where I've heard this, it's been interesting where somebody said, I had a kind of a bond with my dad. I thought we had the same, mutation or the same family history. Now I feel it makes me feel close that I share that. So some people can feel a little bit not sure what to do with the negative result, feel a little bit more isolated or lose a bond that was really forming around a cancer risk in the family. They documented and told us about that. The other test result you can get, and your genetic counselor may have referred to this, sometimes they couldn't find a gene mutation, but there's sort of uncertainty. They say it's inconclusive. We didn't find anything. That's open to misinterpretation. Some people feel, okay, well, that's relief. I don't have to do any screening at all, which may not be true. That may be a misinterpretation because it may be uncertain, but maybe you still need to be followed to some extent. It can be confusing. Some will continue to worry because now they didn't receive that benefit of increased certainty. One of the things about testing positive is even though it may be not good news, it gives you its certainty. So now you can feel propelled to move forward into options that may be offered or things you can do. And you may be told it can impact. Some people will choose not to go for follow-up, and other people may still want to hold on to intensive screening. And there is a need by these people, I think, often to have updated to make sure they're getting updates on any new knowledge in the field that may change that result. And we have documented positive psychological consequences. So people feel it propels them to make tough decisions like prophylactic surgery. People feel now, okay, I'm going to be in a monitoring program, surveillance. I'm going to be watched closely, and that's really important to me. And I feel good about it. Others feel it's changing their lifestyle and their prevention. There's some things that they feel more sense of control. I'm going to take care of myself better. I'm going to watch my health and lifestyle behaviors. Other people have like an existential, this is not uncommon. Like all of a sudden, it has a way, just like a cancer diagnosis, it might shift your priorities, like what's really important to you. May become very salient, very prominent sense of your values, what you want to be spending your time in the event you get a cancer diagnosis or given the fact that you may be at high risk. So you might live in the moment more, have a greater appreciation of life, and feel empowered about what you can do or should do rather than feeling like a sitting duck or helpless. And there's been a lot of hope documented for future treatments and new medical interventions, and they will be coming down the pipe, I think, and hope for the next generation. I've seen a lot of that in the literature and in the interviews we've done, and they can feel closer to their family members. These are some of the positive. So what do we do to help people? So the factors associated with adjustment, one of the things our team and others have documented, and we have even tools to help find individuals. We wanted to know, well, who is the subgroup that have more trouble adjusting with the new genetic information, even if it's negative and they're still not adjusting? Those who have had a past history of mental health or depression or anxiety or trauma, they may need more psychosocial support. Not always, but it may affect how they do with this. So that's sort of just something to think about going through the counseling. If you know you've had a depression in the past or currently, or you've had psychotherapy in the past, it's not a flag for sure you'll have a problem, but it is something to think about. You may need more psychosocial support. How the perceived illnesses. I mean, do they feel there's something you can do? Do they feel like there's options? Are there available prevention options? If people feel there are things they can do, they may feel better about it and feel less distress over time. The prior family experience, if there's been a lot of loss, for example, or you were a young person when your parent died, like in adolescence, those individuals may need more psychosocial support along the way in either going through the genetic testing process or after. And if you feel that there's something about that threat of illness now, like, I've seen this so many times, and it's not again based on fact, really, but somebody may say, my mother had cancer at 40 and I'm 39. I feel like I'm getting anxious. Until they get past 40, it's really interesting that perception can play a role. If you expected to um, receive, if you didn't expect to receive a positive result, that can be an issue. Um, Women tend to have had more distress, but that's not always the case. And your coping style will play a role. So people that go on the internet or they worry about things in general, or if you're someone who avoids clinics and avoid the internet and you avoid information, that actually has been associated with more distress. Or if you're kind of an emotionally preoccupied kind of coping style, you may need more support. If there's diagnoses or things going on in the family, obviously you might benefit from support. Or if you're going through some decision making, and there are a number of decision aids to help people sort out, do I want a prophylactic surgery? Do I want to go through genetic testing to help you make your personal decision based on choices and your own values and your own perceptions? And this is just an example of one of our publications, but there are a couple of others out there where we actually have a bit of a tool to help the genetic counselors and geneticists decide who should maybe get a referral to psychosocial support. Now, counseling is available through psycho-oncology programs, or if you don't have access that way, in mental health programs in your community or through your family doctor, because it can help you engage with the information and sort of take an existential approach and say, okay, given the face of what I'm confronting, how do I still live life fully in the face of this information? And I did a whole lot of studies and groups around, this is one example. I actually did a lot of group therapy studies showing benefit, bringing people together who carry the mutation so they could share information. We can help them grapple with the concerns they had, help them cope, get information they needed, and also just help them make decisions and go forward. These are well published. And these were the types of topics we explore in those support groups. Family impacts, the psychological impacts that I talked about, and the medical treatment. And what do I do? Should I do this? Like, they're really hard decisions to be thinking about prophylactic surgery, just taking a look at the time. And so now in the field, and you should reach out. Some people don't need much. They need maybe a little bit of psychoeducation to teach about coping or managing anxiety and to make sure they understand the genetic information and its relevance. Self-help, there's a lot out there around, like Forest is an example in the breast area where Wellspring's been offering things. I mean, where people can get information, or there are sometimes disease groups that will actually support an area in genetics to bring people together, one-to-one peer support. And I think that can be very helpful. Problem-solving intervention or decision aids. If you're going through genetic testing, or if you're going through prophylactic surgery decisions, It's okay to see somebody for a few sessions and for you to clarify your own choices and make a very informed decision. Because just because a family member or physician or someone says you have an option for this or you should do this, we know that people adjust better if you make your own informed decision and you have clarity around your choices and why you're pursuing something. But there's been a lot of interventions developed in the field. They're not always easy to find. Some may be online. But again, I would really encourage you, if you live in rural or live in a small town, reach out to your GP, your family doctor, or a local mental health clinic, because a social worker or psychologist could help you work through the issues. Or in a cancer center, that you could maybe ask for referral to psycho-oncology or ask your genetics team for a referral to mental health. And these are some examples on decision aids, like, do you know the risk and benefits? How clear are you about those choices? Do you have enough support? Like we have questionnaires around this, and decisional conflict's common. And we ask questions on these tools like, what helped you make the decision? How did you feel before? I mean, we know they're difficult, and it's a whole process using a decision aid where you're really doing a shared decision making with a professional to help you work through what are your preferences, what's feasible for you, what's your preferred choice, not what you're. These will all help you gauge what decision you probably should make best for you. And we know they help. There's a whole research on this. They clarify values, they give facts. Often these decision aids have factual information about the type of choice you're making and steps in guiding you in a very intentional way to make that decision. And some of them are for genetic testing, some are around risk reducing surgery, some are around prenatal testing or infertility, some are related to surgical related decisions around an actual cancer diagnosis or treatment. They're using genetic information for treatments of cancer. And these are the types of issues on a questionnaire that you'll see that you'll endorse. Like, I have enough information to make my choice. The choice is clear for me. I'm sure about what to choose now. Because decisional conflict refers to kind of distress around a decision where you're feeling conflicted. You don't know which way to go on the decision. And then I just want to talk about resilience. I don't have much time. I better leave time for questions. But what we want to do with our patients is foster a sense of resilience. So your ability to work with adverse information and do these anxious screening exams. So again, it can have to do with your challenges you've already had in life. Sometimes people have more resilience if they've had to deal with life adversity already. And I've seen that a lot in these families. Having clarity of your own personal goals, having a network and a community, friends, family around you, and your own personal characteristics, like your coping style and being flexible in your coping and resilience, fostering. There's things you can do like mindfulness. These are just programs we know are good for resilience, support groups, or just having support in your life, friends, life meaning, spirituality. These are all things we know help with fostering adjustment and resilience in general around stress in life. Opportunities to reflect and talk about your feelings and figure out what's important to you in life. And then, of course, counseling. And there are different models that maybe one-to-one, it might be a group counseling that can help you deal with your own coping. So I think I'm going to finish because I want to leave at least 10 minutes. Not everybody does the same. Not everybody's going to react the same in your family. It's a genetic testing's a family affair, and the health status can change over time in families. So it's kind of lifelong, this whole genetic information. And we know for some cases, just getting information alone may not be enough to fully address your needs and taking in the information. So I'm going to finish there and I'll stop sharing. And then I have a few minutes. There's 10 minutes, I guess, or so for questions. Sorry, I'm a bit rushed at the end, but I thought I better leave a bit of time. And thank you again for having me.